All right, thanks everyone for coming to my Lunch and Learn. I'm Dr. Jeff Watts. A little bit about me, I was born and raised in Northeast Ohio in Youngstown. Went to Youngstown State for undergrad. Lead Common Erie, PA for med school, and then did my internship and residency in orthopedics at St. Joe's, and that's in Warren, Ohio, about an hour away. And then fellowship in spine surgery at TBI in Dallas. That place is famous for being the place where Tiger Woods had his spinal fusion. We got that a year after I left. Otherwise, I'm sure we could have become friends, golfing buddies. And then from there, I went to South Bend, Indiana, or just outside South Bend, Indiana. And then came here in October of 2020. So today's objectives, this is the same lecture I typically give. Like the public, I think it's a really good kind of overview of, as far as education on specifically back pain, the causes. We go over some of the anatomy to help you understand it a little bit more, common causes of back pain, prevention, treatments, and then expectations after surgery. So as far as anatomy, we'll go over the basic anatomy of the spine, common injuries, and then also degenerative changes that are common. So the spine, 33 bones, 7 cervical vertebrae, 12 thoracic, 5 lumbar, and then you have a few sacral and coccygeal segments that make up the rest. In between each bone is an intervertebral disc, and behind at each level, in between the bones are what they call facet joints, and also 31 pairs of spinal nerves that exit on the way down. This is kind of a nice diagram of that. We'll go kind of fast and hit the high points and leave time for questions. And these are some of the common kind of parts of the body that are innervated in the different levels. And any one of these can cause problems, so you can see how this can become pretty complicated when you're trying to assess a patient who's having back pain or radicular symptoms or all of the above. This is a nice diagram here. Can you see that cursor that I'm moving? So here you have a vertebral body. This is in front, intervertebral discs between the bones. Back here, these bones reach around and touch each other on both sides at every level at what they call facet joints. Back here, you have the neural arch, which is kind of like a tube formed by the bones. You have a spinal cord. The spinal cord typically ends at about L1 and then travels down in the dorsal sac just as spinal nerves, and at every level in between these bones you have a hole here called a foramen, and a spinal nerve exits on both sides at that level. And this is kind of the distribution of some of the spinal nerves, and if somebody does have a stenosis or a pinched nerve and they're having radiculopathy, these are the common areas where you'll see symptoms associated with a certain level. It's not exact. Doesn't always follow this exact plan. This is a general idea here. And radicular pain used to be referred to as sciatica. You hear that term a lot. People kind of throw it around. But the more proper term for it is radicular pain, radiculopathy.
OR1 to PACU, OR1 to PACU.
So again, we have intervertebral disc, which kind of act as shock absorbers. You have the vertebral body, which is the bone that supports and protection of the neural elements, and the facet joints are where you get your mobility. This is another picture here. This is a cross section here. You can see kind of the anatomy of the disc. Typically, I kind of tell patients that the disc, especially when you're young, is kind of like a jelly donut. Out here you have a fibrous ring of tissue that's pretty tough, and that's called the annulus fibrosis. And then inside you have what they call the nucleus pulposus, which is kind of like a jelly-like material, and that's contained within the annulus. And you can see the proximity here to spinal nerves and spinal cord, and then once you get down a little bit farther, just the dural sac itself. And there's a picture. Anatomy picture while you're eating. So back pain, we're going to talk about the epidemiology, the difference between acute versus chronic pain, and then we'll touch on infection too. That's too important right now. And then pain pain syndromes. So these are syndromes that cause pain, and it can cause pain anywhere. And frequently, if it's in the neck or back or extremities, these patients get referred to spine surgery, but there's not actually a structural cause of their pain. This is things like fibromyalgia, where there's not really a surgery per se to help with these things. It's important to kind of pick up on that and recognize that, so that you avoid putting someone through an unnecessary surgery that's not going to help them. Pain. So epidemiology: 80% of all people will experience severe back pain at some point. It's the second most common reason to visit a doctor, fifth most common reason for hospitalization, and most common in patients 45 to 64. So kind of the economic implications: 83 million Americans experience at least some level of back pain. It costs about $50 million a day in lost productivity, $100 billion annually, 15 million annual office visits. Most common cause of pain, most common cause of disability, missed work. And then for the patient, obviously it affects quality of life, loss of function. So acute pain, this is limited and usually occurs in response to an injury to tissue, and then stimulation of pain receptors serves a protective role physiologically in preventing further injury. If you sprain your ankle, don't walk on that ankle. It's kind of the body's way of saying that until it heals. Obviously, this pain should heal or decrease with time as that injury heals. And then, of course, you can have what and this is frequently what I see is acute exacerbation of chronic pain. So somebody who's had back pain. They'll tell me, I've had back pain for 20 years. And then, a few weeks ago or a month ago, I was bagging leaves and it got worse. So that's the definition of acute exacerbation of chronic pain. Chronic pain is considered chronic. It's present for greater than 3 to 6 months, depending on what you read. May or may not be associated with any single pathologic process. It differs from acute pain in that tissue injury may not directly correlate with the level of pain. So this is more chronic degeneration. People with arthritic knees, for instance, they have kind of waxing and waning pain, but it's not specifically due to an injury, more due to degeneration and inflammatory waxing and waning. So acute pain is considered a physiologic response to injury, whereas chronic pain involves more complex mechanisms that may have behavioral and psychological components, and this is the one that's a significant contributor to disability. So injuries of the back: sprains and strains, and then we have injuries to the disc, and that could be anything from an annular tear to a herniation. Fractures: you can have traumatic fractures, you can have stress fractures, and then insufficiency or compression fractures, and then which injuries cause instability and when to see a doctor. So typical treatment for back pain: rest, bracing, activity modification, medications, physical therapy, other different modalities. We talk about like chiropractic manipulations, massage, acupuncture, all that stuff, injections, and then finally surgery. So common causes: heavy physical work, bending or twisting, heavy lifting, awkward positions, standing, sitting in one position for too long. When you should see a doctor: so pain that's limiting your mobility or your ability to walk, neurologic symptoms, so numbness, tingling, weakness, especially in the arms or legs, fever, chills, nausea, vomiting, severe headache, things that can indicate possible infection, and then changes in bowel bladder function. This comes with what they call Pata equina syndrome, severe stenosis or a large disc herniation can cause enough compression of the neural elements to cause you to have issues with bowel and bladder function, and that is an emergent diagnosis. So again, it's just kind of the same thing there. So the difference between a strain and a sprain. So a strain is stretching or tearing of muscle or tendon or any soft tissue. Sprain is stretching or tearing of ligaments. I think I'll just put this in here just to kind of give you an idea of how complex the anatomy of the back really is. Some of them have the bony anatomy, and then you have all this soft tissue anatomy. You have fascia and different muscles going every which way. So a lot of stuff back there that can be injured. As far as a strain sprain, signs and symptoms, back pain, you may or may not have swelling and muscle spasms. Treatment for this typically is rest, ice, anti-inflammatory medications, bracing for at least a short period of time just for support and comfort, and then some injections that I don't really do, trigger point injections, things like that, actually into the muscle. Now we're getting into injuries of the disc. So this is an annular tear. So we talked about the anatomy of the disc, how you have the outer fibrous ring, which is the annulus. Inside is the nucleus pulposus. So this is not a disc herniation. This is a tearing or fraying of the outer ring of the disc. And I kind of, when I talk to patients, it's kind of analogous to like a meniscal tear in the knee. You have this kind of firm, fibrous-y, soft tissue, and it is prone to injury, but it is not a disc herniation. So, injury resulting in stretching or tearing of the outer ligamentous region of the intervertebral disc, the annulus fibrosis. Signs and symptoms: back pain, and you can get occasional radiating pain because we talked about the proximity of the disc to the nerves that come out. So anything that causes inflammation in the vicinity of a nerve root can cause referred pain or radicular pain. You may or may not have muscle spasms with this. And this is a good picture here showing that. So we have our disc, we have our annulus fibrosis around it, nucleus is contained inside, and you can see this tear going through here. Now there isn't, what differentiates this from a disc herniation is the nucleus is still contained inside the disc where it's supposed to be. We'll get to the difference in a minute here. This is just kind of another diagram of this, and you can have, just like with meniscus, you can have an acute annular tear as a result of an injury, and you can also have chronic annular tears over time, just part of the degenerative process, similar to a meniscus tear. And this is what can happen though when you do have an annular tear. So once you do that, you kind of lose the integrity of the disc that contains this nucleus, and you can start to get leakage of this nucleus out through the area of the tear. And again, you can see how it can cause inflammation and even pressure on these nerve roots here. And eventually, as this progresses, it can lead to an actual disc herniation. Here's an annular tear with a bulge, and you can see some of that nuclear material is kind of being squeezed out into the layers where it's not supposed to be, causing bulging and pressure on the nerve, inflammation, etc. So treatment for this: rest, anti-inflammatories, activity modification, and you can do epidural injections with this, typically epidural steroid injections. Steroids, powerful anti-inflammatory. You inject that into the area of inflammation to calm down the symptoms. It does not get rid of the disc tear. It doesn't make it heal. It doesn't make the disc bulge go back into the disc. You're just treating the symptoms here. And now we talk about an actual disc herniation. So this is injury to an intervertebral disc that results in release of the nucleus tissue through a defect in the annulus. Signs and symptoms: much more commonly here, you're going to get radicular pain, shooting down the leg, numbness, tingling, weakness. With a really large disc herniation, you can get cauda equina syndrome, which is the bowel and bladder dysfunction, numbness, or loss of control of bowel bladder, which is an emergency. And here's some stages to a disc herniation. You have a normal disc. You have degeneration, where you just get kind of weakening of this annulus and bulging. So a lot of people come in and they talk about bulging discs. They've been told they have this many bulging discs on their scan 5 years ago. That's a natural part of aging. This, with time, bulge. But it doesn't necessarily mean that that is the problem. There's people walking around with bulging discs. I'm sure if I MRI'd myself, I'd probably have bulging discs in there. I'm fine. I'm walking around. It's important when these people come in, you get imaging, that you recognize what's an incidental finding and what's an actual finding that's probably causing their symptoms. Prolapse, or in other words, the bulging. And then you get into extrusion, where this material is actually starting to come out of the annulus, and then sequestration, where this material actually leaves the disc completely and goes into the canal or into the foramen and causes problems. And here's an MRI, typical of what you'll see with a herniated disc. You can see this material here is not where it's supposed to be. It's kind of squirted out into the canal. Treatment for this: Rest, anti-inflammatories. This is where we start to get into the use of medications like gabapentin or Lyrica. These medications help with radicular symptoms for radiating or radicular pain, and then obviously injections. You can do epidural injections into the epidural space, or you can do selective nerve root block. They're very similar. The only difference is how far you push in the needle. If you go actually into the epidural space with the needle, it's an epidural injection. If you leave it kind of out of the foramen and you just kind of bathe the nerve root, that's a selective nerve root block. And then surgery for these is a discectomy. Discectomy surgery is where you go in and you just remove the piece of disc that's herniated. We're not removing the whole disc. Patients often think that if you take the disc out, what are you going to put in there? So we got to kind of explain that you have a piece of your disc that's not where it's supposed to be, that's causing problems. We're just going to go and get that piece of disc out. A little bit about fractures. I'm not going to get too into this. The most common thing we're going to see here is either stress fractures or insufficiency fractures. So this stress fracture, this is a fracture of bone caused by repetitive stress or force, often from overuse. And the part of the bone in the back that this most commonly affects is the pars, and we typically see this in young people. And this is why the x-rays I get on younger people are a little bit different than the x-rays I get on older people. We typically get oblique views on younger people because that's the best way to assess for any kind of stress fracture. Older people typically don't get stress fractures. So what we do on them is flexion extension views to assess instability, things like that from degeneration. Signs and symptoms of this: back pain can be radiating again. It can be in proximity to those nerve roots causing radicular pain, typically younger patients. The pain is usually worse with movement and relief with rest. And this is the part of the, where we most commonly see this is the pars. So if you're looking at this bone here, you have an articular surface up here that connects with this joint. You have one down here that connects with this joint. This piece right in here is the thinnest part of that bone called the pars interarticularis, and that's where you can get that break, that stress fracture. And the term for that is spondylolysis. So here we have intact pars, here we have spondylolysis, meaning a fracture, and here we have spondylolisthesis, meaning there is some displacement or instability there. There's a difference. It's a CT scan. So treatment for this: rest, activity modification. Bracing, again, just for comfort and support. I typically do that for a short period of time until the acute symptoms have resolved. Anti-inflammatory medications. And then you get into, if it is a surgical issue, repair of the fracture versus fusion of the level itself. I think that's getting into a little more detail than we need to do today, but prevention for these, all of these: maintaining a healthy weight, weight loss, regular exercise, strengthening, especially core and lower back, range of motion, conditioning, appropriate rest in between exercise, avoid bad biomechanics, certain exercises like deadlifts or something that are strenuous on the back. If you're lifting things, I always say lift with your legs. That doesn't make sense. And then maintaining good bone density, especially in older people. Same thing. We talked about that. So now we're going to talk about, so those were injuries, those are causes of acute pain. Now we're going to get into causes of chronic pain. So remember, this is pain, depending on who you read. It's been there greater than 3 to 6 months. So most common causes of this: degenerative disc disease, facet or sacroiliac arthritis or arthrosis, stenosis or narrowing, causing pressure on the neural elements, and then you see deformity as a result of all these things. So degenerative disc disease, chronic degeneration of the intervertebral discs. Signs and symptoms: back pain, loss of range of motion, stiffness. This can lead to stenosis or narrowing, and subsequent symptoms: radiating pain, radicular pain, numbness, tingling, weakness, or it can be asymptomatic. And this is just a diagram of degenerative disc. So you have a healthy disc, and over time, no matter who you are, your discs are going to thin. With time, they're going to bulge out a little bit. As they get severely degenerated, you can start seeing these osteophytes here, or bone spurs. These are all common findings in patients that we see. So another diagram of the same thing. So treatment: activity modification, anti-inflammatories, regular exercise, physical therapy, injections. again, the same kind of theory, especially in the epidural space, where you're actually going to get the injection to the area that's causing the inflammation, in this case the disc. And then surgery for this. For degenerative disc disease, there aren't a whole lot of options. You're either talking about fusion or disc replacement surgery. Disc replacement surgery, as far as I'm concerned, has a very narrow window of patients who are candidates for this. This is typically patients who are younger, who only have one isolated disc that is causing the problem, and no degenerative changes elsewhere, no degenerative changes in the facet joints. Fusion is pretty much an option for anyone. So now we're going to talk about arthritis, arthrosis. Arthritis is joint inflammation. So remember we talked about when we're talking about anatomy, you have the discs, and then behind that you have the facet joints at each level. Those are true joints. They are synovial joints, and you can get arthritis just like you can get in your knee or in your shoulder. And arthrosis is joint degeneration. So our facet joints. That's the greatest picture. Let's see if we have a better one. But signs and symptoms of facet arthrosis: back pain. You'll have tenderness over these particular joints because they are palpable on physical exam. Patients will complain of stiffness. This can lead to stenosis because part of arthrosis is we talk about bone spurs forming, or these joints getting larger over time just due to chronic inflammation. And I've seen these joints get very large. And they can cause stenosis, impingement of the nerves, and radicular symptoms. There's another good picture of the joint. You can see these holes here, the foramen where the nerves come out, and then also the spinal canal itself. If these joints begin to get bigger and bigger, you can see where it can cause problems with narrowing these areas. So treatment, activity modification, anti-inflammatory is pretty typical. You can add these medications like gabapentin and Lyrica if they are having radicular symptoms. Preventative kind of measures include regular exercise, maintaining a healthy weight. Can add physical therapy into there. Injections, and this is why it's important to determine what part of the back is generating the problem, because injections for this are different. These are intra-articular injections into the facet joints itself. These are not epidural injections. And then medial branch blocks, again, that's probably getting into a little too much detail, but there are little nerves that are responsible for transmitting pain from these joints, and you can target those nerves with what they call a medial branch block, and also a radiofrequency ablation or rhizotomy, where you go in and burn the nerves. This is what patients are talking about when they say they've had their nerves burned. It's basically burning those afferent nerves that go to the facet joint to kind of block the transmission of pain from those joints. And then obviously surgery is fusion surgery. That's just another, this is what I was talking about here, the medial branch nerves. And here's a picture of the medial branch nerve. You can see where you go in, this is the medial branch here that's supplying these facet joints. And if you go in and you either block that with an anesthetic, or you burn it with heat, you kind of get rid of that nerve. Unfortunately, they do grow back. And this is another common one that I see a lot of, sacroiliac joint inflammation. So signs and symptoms of this. Localized pain and tenderness over the sacroiliac joint itself, typically not relieved by sitting. Treatment, again, activity modifications, anti-inflammatories, regular exercise, physical therapy. Injections for this, again, these are not epidural injections, these are injections into the joint itself, the sacroiliac joint, and then surgery is a fusion. So your sacroiliac joint, this is your sacrum or tailbone, and this is your hip bone here that you can feel. Back here on either side you have your sacroiliac joint, and this is something I commonly see in older people, especially people who have had a spinal fusion already. For whatever reason, they've had a spinal fusion, and that just begins to transmit more stress to these sacroiliac joints. So they come in with these symptoms, and again, it's important to kind of distinguish that is in fact what's going on, because nothing I do up here, if they're having sacroiliac joint pain, is going to have any effect on that. So you got to be kind of open-minded, not have a narrow focus that everything is always coming from back, it could be severe injury. And then we'll talk about stenosis. This is the narrowing of the spinal canal or the foramen that we talked about. You have your central canal and then your subarticular and foraminal regions off to the side. Signs and symptoms of stenosis: radiating pain. So pain going down the leg or down the arm if it's in the neck, numbness, tingling, weakness, especially in the lower back with prolonged standing and walking. This is called neurogenic claudication because this impingement changes its positional. So if you're standing, those foramen tend to close down a little bit more. When they sit or they lie down, they open up and take a little bit of that pressure off, and this is why they'll say, my legs go numb when I stand and walk for 100 feet. This is an example we kind of talked about when these facet joints get big and overgrown, how they can cause pressure on these nerves here, can cause narrowing of the central canal. And here's a normal picture. Here's the nexus. I don't know if that's a good picture. But okay. So that's kind of an overview. Let's see what else we got here. So treatment for stenosis, activity modification, anti-inflammatories. The problem is stenosis is not going to get better no matter what you do, no matter what activity modifications you do. It's a structural narrowing. So the only thing you can possibly do is go in and decompress it surgically. You could try epidural injection, you could try all these things. But when someone has significant stenosis, I pretty much have to talk with them that no matter what we try, the stenosis is going to be there. So the only thing we can do is go in and decompress those neural elements. Deformity, I don't think we really need to talk about. So the last thing we'll talk about, fractures, insufficiency, or compression fractures. So these are a type of stress fracture resulting from normal stresses on abnormal bone. So the stress fractures that we talked about earlier were the bone quality was normal. They didn't have an issue with the bone. It wasn't low bone density. These are typically young people that have good bone density. This is from repetitive stress to a kind of vulnerable area of that bone. This, on the other hand, is from normal stresses on abnormal bone. So people with low bone density, or people who have, pathology in the bone, metastatic tumors, things like that, that affect the quality of the bone, can suffer fractures from normal things. Bending over to tie their shoes, coughing, sneezing, anything like that. You can also get these in the sacrum. To determine this, if you do an X-ray, somebody has a compression fracture, you can see typically the compression fracture on the X-ray. And if you do another X-ray 20 years from now, you're still going to see a compression fracture there, even though it's healed. That's always going to be there. So the way to determine whether or not this is an acute fracture or a recent fracture is an MRI or a bone scan, just to see. This will show the actual inflammation in the bone, and then you can determine whether this is acute and that affects your treatment options. And obviously, you want to rule out other pathologic causes, like I said, metastatic disease, things like that. So back pain is the most common symptom, especially with activity. They can also have some tenderness in the area, and then kyphosis or hunching forward because of the, you can see the deformity that it causes here. That actually causes the spine to tilt forward. This commonly happen on the anterior aspect of the bone. There's an MRI showing a fracture, and this lighting up is typically what we're looking for here. That tells us that that's a new fracture. Treatment, activity modification, bracing, anti-inflammatories. With time, like any other fracture, these fractures will heal and they'll stop hurting, but that deformity will always be there. The most important thing, especially if it's due to low bone density, is talk with the patient and tell them, you have to talk with your family doctor about getting assessment for low bone density and then getting on treatment, because you're going to be at risk for more of these in the future. Low bone density doesn't just affect one part of the skeleton, it affects everything, so you're at risk for hip fractures, wrist fractures, that kind of thing. Surgery for compression fractures is vertebral augmentation or kyphoplasty. This is only good for acute fractures. So if somebody has a compression fracture 10 years ago and they come in to see me, kyphoplasty is not an option for them. This is an old fracture, it's healed. Me going in and putting cement in that bone isn't going to do anything. So we'll typically order an MRI bone scan for any kind of suspected compression fracture to see how acute it is. vertebral kyphoplasty, kind of splitting hairs here. Essentially, it's you go in with, you can see got a picture, yeah. You go in with this cannula, and you typically inflate a balloon in here, which you try to restore as much height as you can. Take the balloon out, and then you fill that void with cement, and that cement hardens instantly and should give them support and at least, you know, some relief of their pain. It could still take some time. It's not always instantaneous. But here's an X-ray of somebody who's had a kyphoplasty. It's the same thing. Insufficiency fractures can affect the sacrum with enough low bone density. You'll see this especially in very old people. They get kind of compression of the top of the sacrum. There's not really a lot of good options for this. I don't do kyphoplasties on this. I know there's probably some people out there who do. Typically for this, it's just activity modification, rest, and anti-inflammatories until that fracture heals. Okay, talk about that. What do I do when I see somebody for the first time? Obviously, the most important thing is taking a history, talking to them, telling me to describe their symptoms, how long they've been there, what their history is, how long has this been going on, have you ever had back surgery, what other treatments have you had injections, have you had any of this other stuff, fill out a pain diagram, and then obviously a physical examination. Physical examination, typically watch them walk and see if there's any issues with their gait, the way they're walking, how good their strength is, if there's any sensation deficits, we check their reflexes, and then we look for certain areas of tenderness that can kind of clue us in, like we talked about the SI joint, different kind of provocative maneuvers, especially for like disc herniations, things like that. But very rarely do I ever see somebody for the first time, get x-rays on them, and be able to tell them exactly what's going on. You typically, you get a little bit of information from this, but you still want to get some more imaging, you want to get an MRI, because you don't always know, you'd be surprised what you find. Here's a typical pain diagram that I see. So our imaging options, x-rays, dynamics, so we talked about doing flexion extension, that assesses any kind of instability. You'll see movement from flexion to extension. MRI is usually the next thing I'll order for patients who can't have an MRI. The next best thing is a CT myelogram. So this is not just a CT. They do a CT, but the myelogram part is they inject a contrast into the epidural space to kind of give you an idea and show any areas of stenosis or anything like that inside the canal that's not really able to be assessed on a CT without a myelogram. For patients who are complaining of symptoms in the extremities, numbness, tingling, weakness, I'll typically also get an EMG, especially if these symptoms have been around a long time, because it's very common for me to see somebody who comes in and they say, I got neck pain and my hand is numb. My family doctor told me this was cervical radiculopathy. I got a pinched nerve in the neck, and we do an EMG and we find out they have carpal tunnel. So this is very common. A bone scan, we kind of talked about that. I don't order too many of those. These are typically for maybe an elderly patient who you're concerned about a recent compression fracture and they're not really going to tolerate an MRI. You can get a bone scan. Arthrogram, discgram, never really does it then. So we talked about that, plain x-rays. So I want to get into some other things before we run out of time here. Spinal cord stimulator. So spinal cord stimulators is a good device. Essentially, it's an electronic device that's implanted into the spinal canal, in between the spinal cord and the bone. And it kind of interferes with the transmission of pain. And this is a very good option for, number one, patients who may be too old to tolerate a large surgery like fusion surgery, or whose bone density is so low they're probably not going to be able to support any kind of hardware in there. It's just going to collapse. It's good for patients who have painful diabetic neuropathy, patients who have, again, like we talked about, myofascial pain or non-structural issues of pain, like you've heard of RSD, reflex sympathetic dystrophy, things like that. It's a two-step surgery. The first step is a trial. This is done as an outpatient. We just give them some sedation, we kind of calm them down, and then we put in one, sometimes two needles. These wires go in through the needles come out, we put a big dressing on there, and we leave it in for a few days. We bring them back, and we just ask them, did it help? How much did it help? Obviously, if they tell us it didn't have any effect at all, we just pull the trial out in the office, and I don't recommend doing a permanent one. But if they do have significant relief with it, then we can put in a permanent one. It's kind of a picture of the trial, it just kind of goes into the skin. The permanent one is a general anesthesia. We do keep these patients overnight, typically just one night. We do make an incision for this. We make one incision to put the lead in, and then one incision for the little generator. The wire goes under the skin to connect it. So again, indications. Patients who are not good candidates for a more invasive surgery. Patients with very diffuse multi-level disease. In other words, you come in, you tell me your back hurts, and you have stenosis, degenerative disc disease, spondylosis, at every single level I'm looking at. And the only other option is to do a very big fusion, basically fusing your whole lumbar spine, which, that's a life-changing surgery. Or we can try this stimulator, and typically, patients who have that kind of disease are older. Mid-70s, early 80s, and they're not going to tolerate, a large fusion like that. So we try this, and most of them do very well. Patients with chronic pain refractory to prior surgery. I had back pain. They did a fusion. My back pain never got better. Do another fusion. These patients, I'll try a stimulator, and again, they typically do very well. And then pain not attributed to a structural pathology, like we talked about. RSD, things like that, diabetic neuropathy. How much time we got, Sherry?
You have about 8 minutes.
Okay, so, that's kind of an overview. I don't know that any of this stuff is kind of common sense, as far as your algorithm goes. You want to start with the most conservative, so rest, anti-inflammatories, and then you move from there. If that doesn't help, you can try therapy, some other modalities. From there, you move on to injections, and then the last line of treatment is surgery if you think that there is a surgery that can help. So, I think that's everything. And then I just get into the different injections, which I think is beyond. I kind of covered all this. So, any questions? This is something I can touch on real quick. So, post-op, depending on what I do, it's pretty standard. If I put stitches in, those stitches come out in about 3 weeks. If we did not do a fusion, if we just did a discectomy or just a decompression, at 3 weeks when I take those stitches out, I will usually send those patients to therapy, return to normal activity as tolerated. If we did a fusion, we'll typically give them a brace to wear, whether it's a back brace or a cervical collar, and I will give them activity restrictions, and I typically won't start therapy until I see on x-ray evidence of a solid fusion forming. And that could be anywhere from 6 to 12 weeks. And that's kind of a good kind of overview of when I begin therapy. For patients who have a permanent spinal cord stimulator, I typically give that about 6 weeks, because that lead that we put in there can move, and we put it in a specific spot so that you get coverage. If that lead moves or shifts, we're going to lose coverage, and that's not good. It takes about 6 weeks for that lead to scar down, so I'll typically give them activity restrictions for about 6 weeks, and then let them fly. But that's everything. We got some time for questions. You can ask about Tiger Woods, whatever you want.
You mentioned about the burning of the nerve
Yeah.
that can grow back. Like
It
how
will.
long would it, does that usually?
They say it could take up to a year for that nerve to regenerate. And even when it does regenerate, that doesn't necessarily mean that the symptoms will return, or they will return to the the severity that they were before. So yeah.
So how accurate are the pictures on the MRI before you go in and actually do our surgery?
What's What's that?
Before you go in to do the surgery, how accurate are the films on the MRI? You sometimes get in there and see more damage or less, or they're...
No, MRIs are very good typically, unless it's the open MRI from NOMS, which are terrible. It's actually good MRIs. Yeah, we pretty much, I mean, they're extremely accurate, and they can tell you, I mean, you get a lot of useful information when you're going in there. Very rarely. The only time that I think you'll see something different is a lot of times when somebody has a disc herniation, not a very large disc herniation, but they have a disc herniation, and we go in there and we do the laminotomy and we move the dura over and we find the annulus and we make our incision, and sometimes you don't really get anything on it. A lot of that could just be bleeding. It kind of collects in there. It looks like a herniation. So that's the only time where you really, and sometimes, you know, I'll tell them that going in. You know, we're going to go in here, and sometimes we get a big piece of disc out, and sometimes we don't. You really can't tell. So.
What about kyphos? You said you weren't really a fan of those? Or?
No, I am. But what I typically do is, it's just like anything else I do. Anytime we consider surgery, you know, we're treating the symptoms. If somebody comes in and they walk in and they sit down and you know, they have a compression fracture on their MRI, but they're like, yeah, I was just out here before I came here. I was out, you know, raking my yard, and obviously you're tolerating the fracture pretty well. I would say stop doing those things for a little while. Let's give you some anti-inflammatories, give you some restrictions, let the fracture heal. You're probably going to do fine. People who come in and they wheel them in a wheelchair because they're in so much pain from the fracture, obviously you consider doing a kypho sooner
You
rather
just
than
get worried about the other levels on an 89-year-old.
Correct. And I always tell them that, you know, you have low bone density all through your back, and I'm going to go in there and squirt cement and make one level hard
But
in
it works,
between.
so yeah, it's worth it.
Yeah, with the so.
For some of our patients that are not at that surgical level, but they're just experiencing acute pain and everything else, did you go over like recovery from like your injections and things like that? They might be a little bit more hesitant because they're thinking back surgery and it's major versus the injections and the recovery time for that?
Yeah, so with injections, there's typically no recovery time. I have people that, you know, come in on their lunch break from work, get an injection, and go back to work. I do. The biggest risk with doing an injection is getting a spinal fluid leak, and it depending on where you do the injection. So let me find a good picture here. Okay. So right here. You can do an epidural injection straight midline, where you come in straight down here and go right into the canal. And you can see right here is that dural sac with the nerves in it, and there's not a whole lot of room for error here. And this is also true of people who have myelograms or have epidurals for whatever reason. You can get a spinal fluid leak, it's miserable, you get a headache. I don't do midline epidurals. I come in from the side here and from here. So this is why when I do them, I either do one side or both sides. I've actually never had a spinal fluid leak with any epidural injection I've ever done, because we come in here and we kind of sneak in. Let me find a picture from the side, so you can see how much room is actually there when we do it. And that's particularly why. Number one, I think they get you get better coverage with the injection, and then there's almost no risk of a spinal fluid leak in there. Okay, so here. So you see from the side you have this big hole here, this big foramen. Now that nerve will come out and it'll kind of wrap under this bone and it'll kind of go out this way, but there's a lot of room under here, and I typically come in from this angle here and put the needle right here. And there's not really much to hit in that kind of area. So yeah, as far as activity restrictors, I tell patients we'll do the injection, and then pretty much activity is tolerated. Do what you want. If you want to go home and take the rest of the day and lay around, that's fine. If you want to go do whatever you want, go back to work, that's fine too. It just depends on how you feel.
It's amazing.
So when you do the difference between a foraminotomy and a foraminectomy, so it's that hole right there you're making bigger, right?
Yeah, foraminotomy is we're taking this hole and opening it up. Now there's only so much you can do because that's the border of that is that facet joint. Let me try to find a good picture for this. So you see you have your disc up here, you have your bone here, and they come back and they touch at this facet joint. And this is typically what you're doing. You're removing a piece of this facet joint to try and open this hole up. But there's only so much you can do before you create instability. They typically say you don't want to remove more than half of that facet joint. So what we do is we come down in here and we try to open this up as much as we can. Now in a fusion, when I don't have to worry about it, we take everything off. I remove this whole facet joint, both sides, because we're putting in screws anyway and we're going to stabilize it, so it's not a big deal. That's a facetectomy.
When you do a fusion and send them to therapy, we're under the assumption range of motion is tolerated.
Yeah, basically, I try to keep it simple. So basically, when I'm sending them to you guys, they can fly. You know, just activity is tolerated, get it back to normal. You know, at their own pace, everyone's going to be, you know, progress differently. But yeah. So, like I said, I bring them in at 3 weeks, 6 weeks, and 12 weeks, and we check the X-ray. And once I see enough fusion where I'm happy that it's stable, no more brace. You know, they have time to keep it and wear it if you want for support and comfort, but the goal is to get rid of that and then return to activity as tolerated. So whatever level they progress at, if they go fast and they fly through it, and a week later they're doing everything, that's fine. If they take, you know, another 4 to 6 weeks, that's fine.
Burst versus wedge compression, same, different.
So,
as that one yesterday.
Yeah, so a burst fracture by depth. So let me pull this up here. So when you talk about the spine, you talk about 3 columns of the spine. You kind of draw a line right down the center of the vertebral body on the lateral. And this is your anterior column. And then you draw another line over here at the canal. And this is your middle column. And then behind the canal is your posterior column. And by definition, any fracture that affects 2 out of those 3 columns is an unstable fracture. So compression fractures typically just involve the anterior column. The anterior part of the bone will wedge down a little bit. Burst fractures involve 2 columns, the anterior and middle, so the whole vertebral body, and that's by definition unstable. Higher chance of them needing surgery depending on how unstable it is. And then obviously any fracture that involves 3 levels, all 3 levels is a very unstable fracture, typically requiring surgery to stabilize.
So the gal yesterday, was she a true burst or not necessarily?
It depends. So, you know, you have, again, you have insufficiency fractures from low bone density, and I see a lot of compression fractures that technically are burst fractures because they involve 2 columns, but the reason they got it is because they have low bone density. You know, they bent over to pick up their dog and they got a burst fracture. That's a little bit different than a 20-year-old in a rollover MVC with a burst fracture and healthy bone. A significant amount of force is required to cause that burst fracture. So you just kind of.
Now, is she a candidate for the kyphoplasty?
I can't remember who specifically you're talking about. I'll have to look into it. But if you want to go over
I was
that case,
curious.
we can pull up her imaging and I can go over it with you.
Okay.
What made you interested in the spine and the back?
So that's a thing, that's a good question. When you're in orthopedics, you have 2 groups of people. One group of people who love spine and the other, everyone else hates it. I think I just had, when I was a resident, we had really cool spine attendings. And it's just interesting, it's just different than what we were doing, you know. We were doing knee scopes and ACL repairs and shoulder scopes, rotator cuff repairs, and replacing knees and shoulders and hips. And it got pretty routine, and then we would go and spend a month with the spine guys, and we were doing something completely different. I thought it was pretty interesting. So that's kind of